Thank you very much. Again, thanks for the invitation today. And actually, my presentation to this, I think, is an example, maybe bringing together some of the issues that we've talked about today, about place-based intervention, about deprivation, about community funding. So this is actually a research project that we did in collaboration with PUBL, between PUBL and the Health Research Board. And I'm presenting on behalf of my colleagues today, Mr. Martin Quigley and Dr. Patrick Collins from PUBL, Mr. Brian Galvin, Dr. Anne-Marie Carew, and Dr. Sarah Craig from the Health Research Board. So we looked at an analysis of the relationship between addiction treatment data and geographic deprivation in Ireland for the years 2019 to 2021. And the aim of this research was to demonstrate the potential for geographic analysis of addiction treatment data when mapped onto area-based disadvantage using the PUBL HP Deprivation Index. It complements the work of our esteemed colleague, Tats and Jonathan Pratchko, who's here today. So if there's any questions on the deprivation index, it's great. He'll be able to answer them later at lunch. And then to present the findings on the relationship, if any, between addiction treatment data and geographic deprivation. So just to quickly go through the HP Deprivation Index, it's been developed every census since 1991. It's commissioned by PUBL, and it's used really extensively by both PUBL, other state departments, ourselves, and also many academics. Just to note that it was updated with the 2022 census actually this month and has been published. So our research is based on the 2016 census data, but we feel very much that the findings still hold. And then briefly to say is that the index is derived using multiple different variables and indicators of need. And as I say, further information will be available on the website if you wish to look at that in more detail. So where did the treatment data come from? It comes from the NDTRS, which is the National Drug Treatment Reporting System. This is the National Epidemiological Database on Treated Problem Drug Use in Ireland, maintained by the Health Research Board and funded by the Department of Health. It is episode-based data or case-based data because we have no unique health identifier in Ireland, so we cannot identify individuals. However, it does then give us an indication of treatment demand. Since 2016, we've been collecting small area data for addresses through Health Atlas. We're one of the few national systems that can do this. We started this in 2016 when we rolled out our new online data collection portal, but it really wasn't until 2019 that we felt the coverage of small area was good enough to start looking at the data. All publicly funded drug and alcohol services are required to report to the NDTRS, and we've got very high coverage of residential and outpatient treatment. So the methodology. So what our colleagues in PUBL did is they attributed the deprivation index, again based on the 2016 census, to each drug treatment episode for the years 2019 to 2021 at small area level. Then they mapped this on using ArcGIS, and they compared the population of the proportion of the general population in each of the bands to the proportion of drug treatment episodes in each of the bands. And then they calculated drug treatment rate per 10,000 of the population. So there are some limitations to this exercise, and that's what it is, an exercise or feasibility. Treatment patterns don't always reflect prevalence, although they're often used as a proxy. And it also does, especially at small areas, participation in the NDTRS will affect interpretation. and then only publicly funded treatment centres are required to return data to us, so it doesn't include private treatment. So what I'm going to do is I'm going to look to demonstrate the relationship between deprivation and addiction treatment, and we have through maps, through tables, and then through graphs. So we'll start with some maps. So what you see here on the far left, which is the blue and red, is Dublin, and that is the deprivation index is mapped onto Dublin City. The darker blue are the more affluent, and the darker red, the more disadvantaged. And then just simply what we've done is placed beside it, next to it in the green-yellow, is the rate of treatment episodes mapped onto Dublin, the same map. And I think even very visually you can see there's already a relationship between areas of deprivation and areas that have higher rates of addiction treatment. We can look at it in a little bit more detail. This is Waterford City, and again on the far left, we have in the blue-red, we have the index mapped onto Waterford City, and then in the yellow-green, you see the mapping of the drug treatment. Again, just visually looking, you can see that there appears to be a relationship between deprivation and the rate of drug treatment. We can look at it a different way. We can look at a type of drug and deprivation band. So what we have here on the top of the table is the type of drug. Along the side, we have the different deprivation bands. And the first column is the proportion of the general population in each of those bands, again, based on the 2016 census. So if we first look at those who are in the disadvantaged band. So 11.45% of the population lived in a disadvantaged band. And if there was no relationship between addiction treatment and the population, what we would expect to see is that around 11 or 12% of addiction treatments should occur within this band. And that's clearly not happening. What we see is that for all drug treatment, we see that 26.5% of all drug treatments for that period have occurred in this deprivation band. But we also see differences between drug type. The lowest proportion of treatment is for alcohol at 22%, but the highest is for opioid treatment at 31%. So then if we just move up a bit to the marginally above average, where the highest proportion of the population live, where actually most of us live in those marginally above, marginally below average. So here we see 37% of the population live in this band, but in fact only 24% of the addiction treatment occurred in this population band. We also see differences in the type of drug treatment. We see, in fact, almost reverse, is that the highest proportion of treatment, the drug most commonly treated in this band is alcohol, and the lowest is opioids. We'll move on now, and we will look actually at opioids and opioid treatment, again, just using a different graphic to try and illustrate it. Here, we have the general population in the different bands, and they have been collapsed. And then on the far side, we have the proportion of opioid treatment. And I think it's really very clear in this graphic. You can see that 14% of the population live in the more disadvantaged bands, but 42% of all opioid treatment occurs in the most disadvantaged bands. Looking at this again in a different way, and actually what I should have said is that especially at the most extreme ends of the index, the most extremely affluent and extremely disadvantaged, the numbers are very small, so it does make interpretation a little bit, you have to be much more careful. However, what we clearly see here is that the rate of treatment, addiction treatment per 10,000 of population is definitely skewed much more towards the more disadvantaged bands. Interestingly, it plateaus then through the marginally below, marginally above, and then tapers off when we get to the more affluent. Again, is this a factor to do with we don't have the private clinics don't report to us? And then finally, and just in time for lunch, and just to show the power of what we can do with this type of data and how it can be used to maybe better understand what's going on, is that we're going to look at urban-rural divide. So here, closest to me is the urban, and then we have the rural, and then we have the urban on the further side. So if we look at rural first, it's really clear that the trends look quite different. It is also very clear is that alcohol is the most common drug treated in rural areas. We're not seeing such a sharp difference between the more disadvantaged and the more affluent, but there still is definitely a J-shaped curve there. But when we move to the urban, that's when we're seeing real differences. Again, alcohol is still the drug most commonly treated, but we definitely see now the appearance of the other drugs. I mean, for me, when I saw this, what was most striking for me was cocaine. Anecdotally, I would have said the trend for cocaine treatment may have been more equally distributed through the bans. We're not quite seeing that, and that's something, really of interest to look at. Or it may be, for example, the impact of crack cocaine, and we haven't looked at the different, the different types of cocaine in that great detail. So that was my final slide, just to say that this feasibility study has been published and is available on the HRB website for more, if you wanted to read more about it. I suppose for next steps, and in the context of where we are today, is consider how this data can be used for drug and alcohol task forces, for example, but particularly considering the implication for Sláinte care reforms and the importance of having really good data for evidence to be able to measure the outcomes and impacts of any changes that we make going forward. What we would like to do is repeat the analysis with the updated index using the 2022 census, even though we don't think the overall results will change, but I think it would be really interesting to look at that, especially when we could include data from 22 and 23, when we're seeing even more impact of cocaine in drug treatment. And then finally, again, is to maybe look to undertake more in-depth analysis to be able to, again, better understand at a local level what's happening, maybe better understand how perhaps resources can be implemented, and also then the impact of any new projects that have been undertaken. So thank you very much, and enjoy your lunch.